He is joining us with some introductory remarks. We're very much aware from when Alistair was in Parliament, when he was a minister in the Department of Health, about how passionate he is about health reform. And he's now a member of the Health Devolution Commission, which also includes another former East of England MP and indeed Health Minister Norman Lamb, who co-chairs the commission along with Andy Burnham. Alistair has very much, since he left Parliament, been advocating a more localised and joined up approach to both NHS and social care delivery. And he will provide us with a keynote speech as to how he sees the best way forward, what the new structures into care systems, what they can deliver on health inequalities, and can help us level up health throughout our region. Alistair, welcome, and very much over to you.
Great, how's this? I think people can hear this now. You'll need to mute otherwise. Good morning, everyone. It's very nice to see some familiar faces. Daniel, thank you for the welcome, and also be able to say hello to some people who are new to me. So very nice to see everybody, and very nice to be part of the APPG for the East of England again. As many of you will be aware, I've had quite a long connection with the NHS and healthcare generally, which I've not left because I've left the house. My father will be 100 years old next month, and he was one of the founding GPs of the NHS when he started practice. My brother's a doctor. Just over a year ago, I had a heart attack and bypass, which gave me a very warm affection for the NHS, not least Royal Papworth Hospital. During the COVID pandemic, I've been an NHS responder. I've been doing that job of phoning up people who've been isolated due to COVID, and that's been a wonderful experience. And I've just started my training as a St John's Ambulance vaccinator. So there is a reasonable percentage prospect that the next time you roll up for a booster, it could be me. But don't worry, I have a short memory, and colleagues that I serve with needn't worry. All these things are put gently in the past. But all those things have connected me very much with the health service on a practical basis. And I'm very pleased to be able to say a few words about where I think ICSs are going. I'm indebted, first of all, to Steve for his work on with Devolution and with the Healthcare Commission, which I serve on with a number of other former colleagues, as you'll be aware, and for all those who've been part of it in trying to get this area of reform up and running. So let me make a few remarks. We've long worked in the department about the best way in order to secure better integration of services, and particularly in recent years to provide a greater focus on tackling health inequalities. Certainly I'm pleased that the debate is now reaching some form of conclusion with the advent of ICSs, with integrated care services. I do sense through the work with the Health Devolution Commission a serious and paradigm shift in the nation's health services, with more agreement on what's to be done. It really is a tipping point. And the question now is, how can we make the most of this? With the legislation, there's an opportunity for the NHS to move towards a fundamentally new purpose focused on reducing health inequalities, and towards a genuinely new partnership with local government, including social care and wider services. And I do commend the paper you've got in front of you today, commissioned by the University of Essex, on health inequalities in our region, which makes stark reading for all of us. ICSs also provide an opportunity for a goal we've all long sought: parity between physical and mental health services. And having had responsibility for mental health services while I was the Health and Social Care Minister, that's long been a goal. And it's much more often expressed than is seen in practice, but there's a real opportunity now, I feel. ICSs will play a key role in levelling up health. And I think we're all focused on the fact that this now has assumed a much greater importance than perhaps it did in the past. It's no longer fair or appropriate to pay lip service to it. That mission to narrow the gap in life expectancy between areas is just as important in the east of England as it was in Bury, Greater Manchester, where I grew up. And I have to tell you, as I'm now heading towards 67 at my next birthday, life expectancy matters to older people. I have to say, we look upon these things with a slightly different eye than we might have done when I was as young as some of you who are on the call just now. So that gap of 9 years for men, 7 years for women at its worst in the country is a real serious issue for the United Kingdom as a whole, and only fair that we address it. But, and it's a big but, the gap between intentions and practice is wide, and we can't assume that just because we're saying so and just because there's greater attention paid to it, and the white papers have been extremely good on this, that there's inevitability about it. It has to work. We're all aware that the huge pressures on NHS and social services have been greater in the past year. The pressure of COVID, the build-up of backlog, the fact that we have an exhausted workforce, the pressures that we've seen in social care, the issues on recruitment and retention of staff, these make whatever objectives we might have had even 18 months ago just that little bit more difficult to achieve in practice. I see three particular issues that I think it would be useful for public representatives and those in Parliament from the APPG might address in relation to the work of ICSs. Firstly, the inevitable tendency of government and NHS to want to control things. It's always been a bit of a top-down system. It's inevitable. It's ministers who are accountable in Parliament. It's they who have to stand up and answer the questions. Accordingly, not to be in control of things really matters because it's no answer when things have gone wrong. But sometimes that directiveness can be too great. And I found that in the system, and I think we've all noticed that. So that's one thing. The second thing, and it's related, is defensiveness. The NHS doesn't like to be told that things are going wrong. And I encountered that. I suspect we've all encountered that. There's been some reasons in the past, people have got more aware of their individual rights when things have gone wrong. This has produced a defensive reaction from those who might be legally liable, but it does tend to cloud the atmosphere in which problems can be addressed and solutions can be found. And if that defensiveness gets too great, it ends up in a Morecambe or a Shrewsbury and Telford, or in what we saw recently with Essex and mental health services. So watch out for the defensiveness. It's right to be proud of what we do, but when people are asking questions, as you inevitably will, you don't need an NHS that or local authority services that turn in on themselves in order to defend their situation. And the third thing to watch out for, where I think that you can all play a part, is in easing the tensions between different parts of the ICSs. As you look at it, it's either a recipe for bringing people together to find common solutions, or it's a potential battleground as people seek to defend their own part of it and seek to shift responsibility into and financial accountability into other parts. I think those three things have got to be watched, but essentially the structure of bringing people together is fundamentally good, fundamentally the right thing, but really it needs to be worked through with everybody having the same goal and the same intention. And it does need public representatives to drive that. Because what's most important to you and what was most important to me is making sure services that are provided for our constituents are really the best they can be, that they're integrated, that people get answers, and the delivery is very good. They're not interested in who's responsible for what. They're not interested in the tensions between different parts of the system. And they look to us, and they'll look to the new system to be a better way of finding answers to some of the problems than others. It's up now to the 6 ICSs in our region to establish those good relationships and make progress. The guidance from the Department of Health, I think, has become more permissive rather than directive, which is a good thing for the future. And I'm sure in time, ICSs can put health inequalities and public health first. They can finally join up NHS and social care, which is so important, and they can make our health services become more democratic and locally accountable. The Health Devolution Commission has just announced its programme of meetings for 2022, and these are all based on seeking to help ICSs achieve their outcomes by promoting best practice. And just to run through those very briefly for you, the things that we're going to be concentrating on this coming year: health inequalities and population health, system leadership and accountability, place-based partnerships, workforce planning and development, community partnerships and citizen engagement, mental health and learning disabilities, and children and young people, all of which are fundamental to the work of the ICSs and will be fundamental to what your constituents are looking for. I'm particularly interested in sharing best practice. I was always amazed when I was minister that whereas we had these days through modern communications a greater ability to share best practice than we've ever had before, it was sometimes very difficult to achieve. And we've all got something to learn from each other and transmit to each other. The 6 ICSs in our region should be able to do that. You will be on the lookout for them, and do help and encourage that spreading of best practice. So finally, can I say the value of an APPG to me is this. As colleagues who were here when I was here will know, I wasn't the most partisan of politicians. I didn't look for the opportunity to bash the other side whenever I got the opportunity. That's what breeds defensiveness. And that's what makes, in relation to social care and the NHS, potential battlegrounds between parties who are in control. An all-party group, by working together, can ease that partisanship, make it clear that we're not looking for scapegoats, make it clear that one area of success is an area of success for all of us. That's what constituents want to see. They don't want to see polarisation in relation to health and social care. And an all-party group that works together, that isn't afraid to say publicly that it's working together, can make a great deal of difference. So please, pitch into the ICSs, help them through the tensions and difficulties that there will be. Please keep in touch with the Healthcare Commission and its independent work and the advice that it gives. Help us in the areas of study that we'll have, and I hope that that will be really good news for you all in the future. Thank you so much for inviting me to lead you off today. I really look forward to your deliberations in due course. It's great to see you.
So I've got a slight problem. They didn't let me back in, so I'm not on with them now. So,
we just have to wait for Peter to be let back in.
could you ask Steve to send me another link?
Peter asked Steve if you could send him another link.
Okay, I will do. Or he could just take your seat. Hang on, he's here. He's here.
He can't take my iPad.
Okay, sorry. Good point.
I think Peter's there.
Yeah.
There you go. I think I can leave it to Peter now. Really good to see you all. All best.
Alistair, many, many thanks for that.
Like a little snake.
Yes, many thanks for that, everyone. Can you hear me now? I decided it was the echo in the room here that it was best for me to sign off completely whilst Alistair was giving his keynote speech there. Alistair, many, many thanks for that. Have you got time for a few questions, or have you got to get on your way?
I have, but I know you've got other speakers who are probably more expert than me.
What? What we will do, Alistair, we'll thank you for that address, and we'll now move on to the panel responses. We've got 3 of those responses. As I said, many thanks to Alistair for setting the scene there. And we move on to our 3 responses, which are, first of all, we have Ed Garrett, who is Chief Executive of the Suffolk and North East Essex ICS, and he is the region's lead on reducing health inequalities. Ed, it's great to have you with us today, and look forward to hearing from yourself for about 7 minutes as to how you see the situation going.
Thank you, Peter, and good morning, everyone. So, yes, I'm Ed Garrett. I'm the Chief Executive of the Suffolk and North East Essex Integrated Care System. And as I think Alistair's reflected, it's a really exciting time. We've moved from a policy in the health service where competition is the dominant driver, the belief that if we compete, we'll drive better outcomes. And ICS has marked a shift in a different direction to a focus on collaboration between partners and really focusing on local communities. And that's, I think, a brilliant move forward. In that spirit, ICS are around building one team between and an equal relationship between the health service, local government, and importantly, the voluntary sector that have such an important part to play, as well as other partners like universities. And we're seeing all sorts of manifestations of that collaboration and one team ethos, particularly at a local level in my ICS, as we're developing neighbourhood teams in our communities, which are making a real difference, keeping people healthy and independent. But the higher purpose of ICS is around tackling health inequalities and improving outcomes for everybody, but particularly our most deprived communities and our most vulnerable people. We have in our ICS alone an 11-year difference in life expectancy across our system. And for the first time since Victorian times, we're seeing life expectancy fall in certain communities, which is deeply concerning. A quarter of people in our most deprived communities are living with a life-limiting disability, and 60% of people earning less than £10,000 a year suffer from depression. And we know that if you lose control of your finances, you may well lose control of your health. The Chief Medical Officer, Chris Whitty, has in his annual report has offered a particular focus on coastal communities. And we of course have some affluent coastal communities in the east of England, but we also have some that have been left behind economically and see poorer health outcomes as a result. And regrettably, it is often the case that poorer communities have poorer access to services. The NHS, in its role around health inequalities, has an important role to play around improving experience, improving access to services, and I can talk a little bit about that later. But the bigger challenge is around the wider determinants of health. So if access to services affect 20% of our health, the bigger challenge is improving education, employment probably being is the biggest health intervention we can make, having warm housing, clean air, better environment, and all of these factors aren't obviously issues that the NHS can solve, but the NHS has a role now to support partners like local councils to make a real difference. And we're seeing across the east of England what's described as anchor institution movements, where as local employers, we're thinking about what more we can do to support our local community by creating additional job opportunities, by procuring services locally, by being good employers. There's all sorts of work underway. For me, I think good ICSs need to be developing strong place-based plans with local communities and working with MPs and local councillors. And I would pick out the work that's been taking place in Clacton, and I know that Giles Watling's on the call today, but Giles has been fantastic, as has Sir Bernard Jenkins in Tendring too, to work with the local health service to make a real difference. And we've seen improvements in access to services, We've launched an amazing community diagnostic hub, which is also creating employment opportunities, as well as access to services. We've launched a health and care academy. We've doubled investment in the voluntary sector. We've worked with all sorts of partners to see some improvements there. And I think that is the model for the future. It's almost taking the national out of the health service and really creating a local effort that is collegiate and really drives outcomes forward. And I think the pandemic has been great in terms of understanding our communities better and working in a much more local way. So I'm very optimistic about the direction we're going in. What I propose to do now is invite my excellent colleague Susanna Howard, who's done brilliant work on health inequalities in our system, to give you some examples, practical examples of work we've done to bring this to life a bit more. So over to you, Susanna.
Okay, thank you very much, Ed. So I don't know, Steve, if it's possible to share screens.
You mean so you can do a presentation?
Yeah, if possible.
Yeah. Hang on a second.
Okay. So what I'm going to do is I'm going to give some practical examples of how we're taking action on health inequalities. Alistair said at the beginning how important it is to really demonstrate the way that we could work, and hopefully I can show you some of that this morning. So one of the most important functions of the new integrated care partnership aspect of the new integrated care systems is to be a learning system. And we've taken that very much to heart in Suffolk and North East Essex by really kind of embracing the concept of being a learning system as an ICS. COVID-19 was a real wake-up call for us as a system in terms of health inequalities. It really did show that the pandemic amplified, but also exposed many underlying hidden inequalities that there were in our communities. We took that learning forward into our vaccination program, and I think what we learned from this was to really kind of demonstrate how really, you know, we could take very simple steps in terms of making a big, powerful difference. So what you'll see on the left here is some data from the very early stages of our vaccination program in North East Essex. And what you'll see there is that kind of inequality of uptake of vaccinations across different community groups. We took action that you can see on the right-hand side by broadening access to vaccination clinics. We were one of the first systems to develop a vaccination bus, for example, as well. And we really were co-producing with a very broad number of different community groups, different ways to broaden access to vaccinations. And what you can see on the left there is the difference that makes. So if you look at the red line, you'll see the really sudden uptick of vaccinations, for example, in our Bangladeshi and Muslim communities who were training at the bottom in terms of uptake of vaccination. And at the point we intervened, we really managed to turn that curve and change that story quite considerably. So what we felt was really important is to continue to build relationships with a very broad range of different community groups in Suffolk and North East Essex in a number of different ways. So everything from enabling voices to be heard through things like a film competition. And then recently we took the opportunity through a donation from NHS Charities Together to invest in grassroots community groups to co-produce with us different ways of working where there really were significant inequalities. So for example, we know that parts of North East Essex have some of the highest suicide rates in the country. And we also know that Black women are 5 times more likely to die in childbirth than other women as well. And these projects are aiming to actually address those issues and work with us in partnership to try and really turn the curve similarly on those issues. What you can see here are some pictures from the launch of the Unity Centre, the Witten Hub in Ipswich back in September. And this was one of the projects that you can see very much in partnership, evidence on the ground in terms of really bringing together partners to make a difference around those projects. Very, very key to all of this work is, as Ed said, our relationship with the voluntary community and social enterprise sector. And I really want to pay tribute to those partners in our ICS. They're very key partners in our ICS. This is a picture taken just a few weeks ago. Secretary of State came to visit us in the ICS and met with a number of local VCSE leaders who really underlined the importance of supporting resilience in the sector, partnership and investment, as Ed said, as well. And that's a very key part of our approach to health inequalities. And then deepening that are really, developing key roles for people as community connectors. And we've been selected as a pilot site for the East of England around developing the roles of community connectors, and really making sure that, as I said, we keep up that dialogue and we keep talking about the things that are sometimes difficult to talk about and perhaps that we weren't talking about enough before COVID-19. This slide gives you an overview of NHS England's approach around health inequalities, which is around core 20+5. And what you'll see along the bottom here is that we're really focusing in on a number of very specific clinical areas to make sure that we're really understanding in detail how we can reduce health inequalities that we see in each of those disease groups. The approach that we've taken as an ICS is to undertake not just very thorough equality and health inequality impact assessments in all of these areas, but also to develop detailed action plans that we can make sure, if you like, we use to hold one another mutually accountable in the ICS for taking action and making progress in all of these areas. So that theme of taking action is really about the fact that, we shouldn't have just, picked up after COVID-19. We need to work together this way all of the time. And the way that we're embedding that culture is through an approach around moving on the narrative from not just equality, but to health equity, and talking about concepts like allyship, awareness, assessment, and accountability. We've actually now trained around 200 people from across 32 different organisations in the ICS around an approach around health equity. And every single one of those organisations has taken forward small local projects that make a difference around different areas of inequality. That theme around a measurable difference is really important to us, and Ed underlined the importance of anchor institutions. So all of our NHS organisations are signed up to a charter in the ICS to deliver as local anchor institutions. So that's as employers, purchasers and supporters of supply chains, through environmental impact as land and asset owners, and also as part of local communities. And what we're doing is building on that charter to now develop and agree a dashboard through which every board, NHS board in the system, is able to kind of hold itself regularly accountable for the progress we're making, the difference that we're making as local anchor institutions. Lastly, I did notice colleagues from the Chamber of Commerce in Suffolk there, and I have to say one of the most exciting meetings I've had this week has been about beginning to talk about how we can begin to work more with business and looking at how businesses can help us to reduce health inequalities. We're talking about joining up with the Suffolk Health and Wellbeing Board and the Chamber of Commerce around a kind of healthy Suffolk businesses, a sort of charter mark for Suffolk, and also vice versa, working with those local businesses so they can understand how they can build a local supply chain. So for us, we can spend money locally through NHS procurement in a way that drives the economy in the way that Ed described as well. So that's just a little tour around some of the things that we're doing. I'm happy to take questions.
Susanna, very many thanks for that. Ed, thanks for setting the scene on that. If we move on to our next speaker, Tosca Fairchild was due to be joining us from NHS England and NHS Improvement, but she's unfortunately not able to do so this morning. So we will move on to our final speaker, who is County Councillor Bill Borrett from Norfolk. He is the chair designate of the Norfolk and Waveney Integrated Care Partnership. So he's obviously has specific interest to myself. Bill, welcome, good to see you, and over to you.
Thank you very much indeed. Yes, as Peter's already said, I am an elected county councillor. I am the cabinet member for adult social care and public health at Norfolk County Council. I also chair the Norfolk Health and Wellbeing Board, but I have also been appointed by the system as the chair designate of the Integrated Care Partnership, and then there's a lot of initials here for everybody to get their heads round. It would sit in the system with the Integrated Care Board, which is the NHS delivery board. Some of what I've said has been covered, but I'm going to keep the thread of what I was going to say. So, but it's really just at the beginning. We all know, it has been said by the previous speakers, that we have an ageing population and an increase in people with multiple health conditions. We're living longer, but we're spending more of our life in poor health. And these burdens are not spread evenly, with many people, places and communities facing unacceptable health disparities. To deliver on the government's programme of levelling up, it's important that we also level up with health. As we've already heard, ICSs have the opportunity to be the strategic driving force in addressing this ambition, but it cannot be done by the NHS alone. To be successful, ICSs will need to have multi-agency support. And I think to do that, we need to start thinking ambitiously about the role of the integrated care partnership within the ICSs. And has been already said, nothing demonstrates as clearly as the COVID-19 pandemic the strong connection between population health and the economy. It turned the spotlight on widespread disparities across the country. It also created a focal point for local partners to unite around and brought many new innovations into play, which previously had been deemed impossible by the system partners. In my own county of Norfolk, it mobilised partnerships, strengthening relationships across the sectors to enable us to quickly deliver support to the most vulnerable and overcome challenges that may have hampered us in the past. We put in place data sharing agreements which had not previously been possible, combining cross-organisational data to create a shared dashboard to identify those most in need of support. It was very pleasing to see that councils brought together healthcare, voluntary, community and the private sector in community hubs to coordinate local action. We harnessed the strength of local communities to support residents and their neighbours. And we mustn't lose what was achieved. We've got the opportunity now to use the ICSs to level up health with that same spirit. We have somebody called David in the meeting who's not muted, who I keep getting. I don't know if he could mute. David, that's all it says on your screen. Steve, I don't know if you could mute him. Thank you. The response to the pandemic has underscored three things that I think we need to harness within the ICSs, with the new integrated care partnerships playing an absolutely essential role. And the first of those is recognition of what can be achieved when local leaders across healthcare, local government and the voluntary, community and private sectors commit to collaborate with shared outcomes. The second is the importance of taking the right decisions at the right levels. ICSs should work at scale where this is most effective, but we must always, and this is, I think it's really important, keep focus on local places. This is where the direct work of population health improvement takes place and is difficult to achieve with centrally driven systems. And thirdly, is supporting this with data and evidence-led decision-making. And that means we'll need to embed public health at the centre of ICSs to actually interrogate what it is that the local populations require. I believe ICPs are going to be critical to the success of ICSs. Their role will be in bringing together a diverse range of stakeholders, and most importantly, as equal partners. Together, these leaders will develop a joint vision and strategy with an understanding of population health approaches, of each other's roles, and of the challenges at system and place level. ICPs are needed to develop an approach that goes beyond the NHS and will need to combine both the convening and challenging function to all those involved within the system. They will need to coalesce partners around a focus, not on process, but on improving the health and care outcomes and experiences of their populations. This means focusing on the conditions for better health by reducing the factors that lead to ill health in the first place, which has been proved to be extremely difficult in the past. It means looking beyond health and care services to the wider determinants of health and the disparities of opportunity within those. And this includes, this is not an exhaustive list, but early years support, the quality and security of housing, leisure opportunities, transport skills and education, employment support to get people into good and secure jobs, and the environment. All these factors together build good health over a longer period of time, and the ICS will need to commit to a long cycle of change, but most importantly, prevention work. This is, of course, the big vision and opportunities that ICSs should offer. Tackling this agenda will require commitment and consent from a wide range of partners, and is something that councils, with their unparalleled knowledge of their local areas, communities, institutions and organisations within them have, as well as having the strategic overview across all policy areas. This means that they're best placed to lead through ICPs. But in order for them and the systems to do this, it's also crucial, and this is the ask we're asking of the national politicians, it's crucial that wider national policy recognises and reinforces the role of ICPs, ensuring that the strategies related to the Integrated Care Board, with its own responsibility for NHS functions and budgets, flow from the ICP-led strategies, and that resources follow suit, hopefully over time shifting away from acute care into preventative action in the community and public health, moving the system from one that responds to demand over to one which tackles need. And it would be remiss of me at this point not to also highlight how critical it is that social care is put on a sustainable financial footing within this. Councils and the NHS will need to invest in prevention together, and social care must be adequately funded via the new health and care levy. Failure to achieve this will effectively sabotage the whole project. A lot of this will need to be done at a much more local level than ICSs, and we need a system that recognises that place is where most of this work will happen. Miss this and we'll miss a key lesson from the pandemic response. Improving health sits within integrating health and care services at place within our communities who can directly influence and act to address inequalities equally. ICPs will need to drive this broader collaborative action at place. And finally, I'm nearly done. The experience of the pandemic has reaffirmed how important to our local public health systems the ICS will be. Public health will still need a clear long-term future plan, which recognises the challenge we face as a country and addresses the current future pressures on the public health workforce. But it is welcome that national policy has recognised its interconnectedness with other parts of the health and care system and its essential public health's essential role in the ICS. Our public health teams, embedded at both the system and place level, will be critical to ensuring that the ICS has knowledge and evidence to make the right interventions in the right places and at the right level. They are the people who are key to giving us the correct information on the communities that we serve in tackling health inequalities. Thank you very much, Peter, for having giving me the time to address everybody this morning.
So very many thanks for that and for setting the scene so well there. We've now got a session for questions. Can I ask, first of all, those parliamentarians in the meeting, if they would like to raise some concerns and raise some issues? I was said parliamentarians, now it's going to come on to councillors, and Linda has beaten me to it. And so I will just say to her, Linda, ladies first, over to you.
Thank you very much indeed. And no, it's a really interesting session. I suppose my question to the panel is, I was asked to sit on a stakeholder allocation and review for the appointment of NEDs to the Hertfordshire and West Essex ICP. And I guess my concern was that those who had put their names forward for becoming NEDs on this were all health orientated. There was one guy who was from public health, which was great. Everyone else was from a GP practice or a health centre, but they were all health. How do we get the care bit and encourage people from the care sector to actually join some of this and other ICPs? Thank you.
Ed, would you like to go on that one first, just from your perspective, and then perhaps Bill, obviously social care is ingrained in what Norfolk County Council do. give your views as well. So Ed, in the first instance.
Yeah, so I can't speak for Hertfordshire, but certainly from my experience locally, we're absolutely determined that the governance should reflect the equal partnership that Councillor Borrett set out between the NHS, local government and the voluntary sector, and therefore membership on boards should do the same. So I think if that's not happening in your local system, that's an issue to challenge on, and I would be concerned, because what it can't be is, for the reasons we've described, an NHS-led initiative, because the wider determinants of health require all partners to work together, not just the health service.
Yeah, I absolutely agree with Ed. I just wonder if Linda's talking about the ICB. As I say, there's lots of acronyms flying around now, and the ICB is obviously distinct. This is the Integrated Care Board, which is going to be the NHS delivery board, which sits next to, and as I've said, hopefully gives regard to the strategy of the ICP. As their NHS appointments, that may be why that's happened with the non-executive directors there. But I absolutely support everything Ed said. I think that it is really key that we move together as partners, because it's not something that either side, as we've demonstrated in the past, is going to be able to do on their own. So it's only by working together that we're actually going to hopefully make progress.
Many thanks, Bill. And Giles has got his hand up. Giles Watley.
Yes, thank you very much, Peter. This is one probably for Ed, maybe Susanna. I'm just concerned that the new healthcare levy will just disappear into the maw of the NHS and won't go where eventually it's intended to go. And we all know that down the road it'll become a sort of a thought of as a regular part of the funding of the NHS. How would you imagine we can avoid that and make sure that these money to where they're intended?
Yeah, so happy for me to come in, Chair. So I think it reflects the governance conversation we just had. It's crucial that we have diversity of sectors in integrated care systems, so that when we're looking at how resources are spent, we're thinking about prevention in our communities and not what's traditionally happened in the health service, the majority of the budget ending up in the hospitals, which are obviously important parts of the system, but we're not going to make a step change unless we focus much more into social care, into primary care, into the voluntary sector, and those partners working together. So the idea, Giles, is that these new structures will facilitate those conversations. It would be very disappointing if we see the acute side of the health service continuing as they have in the past.
Well, I, for one, will be keeping a close eye on that. Thank you, Ed.
Many thanks, Steve. Many thanks, Giles, and many thanks for your reply on that one, Ed. Any more questions, anyone? I've got one myself, but what I would just pick up in the chat. It's from Jagana from Essex University, has highlighted the importance of data sharing, and just as an observation. We're very much talking about health and the NHS and social care for the councils working together. But I think what's come clear during the talk is that this is very much a team game. We've seen the importance of emphasis of business that came out in Ed's discussion, and that if we had forgotten what the voluntary sector can do, well, the COVID and the lockdown very much brought that right back centre stage. But obviously, we also have on the call, we've got a large presence from University of Essex here, and they've highlighted the importance of data collection and how their team at University of Essex can evaluate the impact of social prescribing initiatives and connected to communities, and they are eager to review various sources and to assess need across the region. Bill, Ghana was very much sort of just pointing that question to yourself, and data protection, data gathering is obviously important in Norfolk. Can you say a little bit more about that?
Absolutely, and thank you for the question, because I think it's absolutely key. We had found that it was very difficult to get people to share. That it wasn't just technically difficult to share data, but there wasn't enough trust in the system for people to want to share their data with the other partners, and I think that was probably the biggest barrier to begin with. So we ran some pilots in very specific areas with to try and create a model that other people or other parts of the system who were responsible for controlling their own data would be happy to come in and share. And I think what then happened is COVID came along, and it sort of changed. It was a game changer, because all of a sudden we had to know where the vulnerable people were. And then we had to share the information, and it was that drove it. But to stop everybody going back into their previous silos, we've worked very hard to continue with this. One of the key issues has been our digital strategy, so that when everybody moves forward with their investing in their IT, that we build a system where it doesn't mean that everybody is using exactly the same system, but at least that the systems are compatible, and that the IT of, for example, social care and the NHS at the top level actually are compatible and can work together. Again, that has meant people not being precious about their own systems, and are having a joint ICS team to lead it from the top. But also, it's not just about the county council and then the NHS. It's district councils and the feeding in of information at a place-based, and I use the word place because it's in all the legislation. But places, I think, fundamentally means different things to different people in the system. So when I'm saying a sort of community or a district council footprint level, basically. Rather than something as big as ICS level. So it's an ongoing an ongoing process. But I think the key thing, so first of all you have to establish the trust that people will trust people with their very valuable information, and secondly, the systems have to talk to each other. And I think the third thing is that the public health has a key role, and I don't think this has happened enough in the past, of actually interrogating our population, actually finding out what it is our population actually needs. We do an awful lot about responding to demands, but actually, who is our population? What are their health issues? So we can then respond as a system. So let's interrogate the population, find out who they are, how well they are, and where they live, and then we can hopefully design networks to support them. And I think in the past, that hasn't, certainly in my experience, that hasn't happened. The system's been led from the other end. So I'm very happy to talk offline about this, and there's a number of people in North ICS who are probably absolutely evangelical about it, so they'd be very happy to have have further meetings if that would be helpful.
Well, very many thanks for that. And Ed, any comment from your perspective on the importance of data?
It is absolutely fundamental. What we're trying to do is shift, as Councillor Borwick said, to more anticipatory care. So acting before there is a crisis rather than responding to a crisis. And there is a wealth of data there that we've learned to use much better during the pandemic. There are university assets such as the University of Essex and the Call, who have a huge amount of data across the public sector that we could be using more effectively. So I think it's an exciting time. A lot of this boils down to, I believe, trust. And if you can get those trusting relationships right, you can make some real progress. So that's the fundamental principle behind ICS is trust. And then if we can share data, we can make some real benefits for the population.
Many thanks, Ed. And next, Daniel Zeitner.
Thanks, Peter. I would try and take inspiration from Alistair's contribution at the beginning and not pick up on some of the big controversial points around these issues, but rather focus on what this group might be able to do. I was really taken with Susanna's presentation on the work that's being done in Suffolk and North East Essex. And I wonder whether she can, or maybe others could say whether that's been replicated in other areas, and whether other areas are talking to each other and learning from that. Secondly, very struck by the input today from the universities, particularly Essex, which is great, but something that I and others have been worrying about for some time, and particularly representing a city with 2 major universities, are health issues within those universities, particularly mental health issues, and a sense that for a long, long time, some of those mental health issues have kind of fallen on the universities rather than on the health service. And if anyone could say anything about how that may or may not be addressed, because of course we are a region with many, many universities. And that brings me on to a sort of further point. A lot of this has been very, very positive this morning, which is great. But I have to say that my sense from what I see in the health services in my part of the world, and also borne out by the public satisfaction survey figures today, is this is a very stressed service indeed. Not surprising given having to tackle the very difficult backlogs and so on from the last few years. So I suppose my question is, how much is this going to be just firefighting and once again rationing, which of course has quite often been sadly the role of the health service, rather than being able to really dig down into tackling some of those inequalities and moving to preventative strategies that we all need to do. I would say that, I mean, in my sense in Cambridgeshire is that people had been working cooperatively and bending the rules for some years for very good reason, that the system was at breaking points and there was no other way of doing it. And I think that's why some of these changes, controversial though they are helpful. So a number of points there, very happy to hear any reflections anybody might have on any of those.
Thanks, Daniel. And Ed and Susanna, would you like to just comment on some of what Daniel's his observations there?
So, I mean, firstly, that there's excellent practice in all 6 ICSs, and people have different systems, have different strengths. Some are more advanced than others, obviously. So I think we could certainly present great work in all of those systems if that was an ask. I think your fundamental point at the end is a very good one about we've got 5-7 years of recovery to do. It would be very damaging if all we do is focus on that as a sort of a mechanical process. This is the challenges we've now got require significant transformation, and I think in ICSs there should be an increasingly integrated management structure. For example, I think we should be pushing, as Councillor Borrett said, on digital as a huge advantage. For the first time, we should be integrating workforce planning and developing health and social care roles for the future and career pathways. I think we should be investing significantly more in the voluntary sector and changing the model of provision with a lot more emphasis upon the voluntary sector, particularly in the area of mental health, where we can make some difference. So I think the challenge for all systems is not to hunker down, but to keep being imaginative and being creative in what's a very, very difficult situation. But Susanna, I'm sure, will have her own thoughts.
Okay, so I suppose I was just thinking, I was also noting the question in the chat about how we worked around the vaccination program. And I think the thing that's really key for me is, Bill underlined the importance of the partnership aspects of integrated care systems. And the thing about working in partnership and taking on that role around inequalities as allies is allyship works both ways. There's definitely an awful lot we can do by reaching out and kind of asking to work with different kind of community groups, voluntary community sector organisations, but the return on that investment in partnership is huge. And in actual fact, that's where we find a kind of real investment back in terms of kind of health and care and what we're trying to achieve. So that very much was evident during the vaccination programme. It's very much evident by the conversations we're having at the moment by trying to reach out to local businesses as well. I think the message here is that health and care can't do it all on its own. We need to work in partnership and we need to be good partners and actually, really practice, that good allyship, which is two-way. And that way, if you like, we involve the whole system, the whole community in rebuilding after COVID and also addressing the inequalities, rather than that just sitting squarely on the shoulders of health and care alone.
Many thanks, Susanna. Bill, any thoughts on Daniel's observations?
I think it's very interesting, and I agree with Susanna and Ed. I think that the system is very stressed, and of course it's going to be stressed. We've just had an unprecedented pandemic, and I think that it's been incredible in what it's delivered. I am concerned that if we focus all the efforts on recovery, we are not going to get a long-term sustainable system, which is where we move again towards addressing the wider determinants and investing in prevention. So I absolutely agree with what Susanna was saying. I think a focus on waiting lists and carrying on doing what we used to do and all of the effort, money and leadership on that at this stage, I think would be a mistake. I think that it's, and very much, I say, supporting what Susanna was saying, we need to focus on this more wider determined preventative approach as part of the recovery strategy of the system. Otherwise, I think that we will lose all the benefits that we've gained through the closer working and the acknowledgement of all the key roles the partners have to play. And also the leverage we get, because the more people who are involved in this, and there's the sense of common purpose, then actually the more that's happened, and the more, and I think it's quite important that communities feel that they are part of the solution, because as then they are, again, far more in control and far less frustrated in the system, and it's a sort of a sense of common purpose. So I do think there is a very big risk here, and I think that it depends on leadership from the centre to stress that, so that we don't lose the benefits. Because if this moving to wider determinants was easy, we would have done it years ago. And it's not easy, but it is the only way that we are going to produce a sustainable, a long-term sustainable health system. And I think that, the game is afoot, as they say. This is the crucial moment where we don't lose all the benefits we've made, and actually we make these ICSs make a difference going forwards, and they don't just become another episode in the long-term NHS story of continual reorganisations. So I think that there is risk involved in this, but it is really important that we don't lose the benefits that we've gained. Thanks very much, Peter.
Thanks, Bill. And moving on, I see Joel Davenport's hands up. Joel, over to you.
Good morning, everybody. Just wanted to pick up on something that Daniel asked about. He was asking about whether some of the good work that's going on in Susanna's area is being replicated elsewhere. So firstly, just to say, great input on the anchor institution piece there in the ICS that's been highlighted today. I just wanted to let you know that there is a network in place that is jointly run by NHS England and ourselves at the East of England LGA to share good practice on anchor institution work. In other words, how can we create better social and economic impact through our work as public sector bodies? And that network's been up and running now for a few months and is really doing well. It's a combination of officers from both the NHS and local government, and is helping to spread some of that good practice that we've seen showcased here today. But we're also drawing in practice from other parts of the country and helping people to share that together. So that was the first thing that I just wanted to mention in response to Daniel. The second thing I just wanted to let everybody know is that We are in the process of doing a response to the integration white paper regionally. We're leading that from ILGA. We're in the middle of that document now for the response by the 7th of April. And we're hoping that, you know, we will have delved into a lot of these issues in our response. So as soon as we can share that with you, obviously we will through Steve. But I wanted to reassure you that as a local government body across the whole region, we are very close to this agenda and working on it with our ADAS colleagues, our directors of adult social care, children's services, district councils, and many others. So, you know, just wanted to make sure that that was known about and that we'll share that response with you soon. So thanks very much again to the speakers today, and look forward to the continued collaboration.
Oh, many thanks for that. Any, I think there's very helpful observations. Any feedback from any of our panelists on what Joel has said?
I just was just going to say that Cheryl's absolutely right. There are numerous networks. I mean, Ed chairs a network between all the ICSs around health inequalities, but that isn't just a kind of theoretical network. There was very active sharing around the vaccination equalities program. In fact, we shared a lot of the work that we were doing immediately across the other integrated care systems. You know, there was a lot of collaboration to get things like vaccination buses up and running and things like that. So that partnership is really important because, you know, when you need to move quickly, you know, sometimes if you like, you know, you haven't got time for an attitude, which is that it's not been invented here. And the other thing is the data sharing. It's not just about sharing between systems, it's also about sharing between sectors. So some of the really interesting territory we're getting into now is sharing data with our voluntary and community sector, for example, as well, around heat spots and so on. So the more that we can use the new legislation to kind of free up that sense of partnership and also to enable us to kind of take down the barriers, I think the better.
I'd just like to add that it is absolutely crucial because the stories about best practice, the LGA has been really helpful, certainly from a social care point of view, because everybody's working in individual silos, and this is all new. Actually, the networks are absolutely vital in supporting best practice, and you know we have. The system isn't prescribed, so every system is slightly different. So it is really useful, and there's an immense amount of good work being done, and the LG are doing a lot to help that be shared. So it's an important part of the whole process.
Bill, many thanks for that. And just picking up in the chat, there's a note from Chiara from University of Essex asking for Ed and Susanna just to give more details the work you've been doing regarding vaccination uptake among the ethnic groups, and she's highlighted specific work that that's been done with the Bangladeshi community in your area. So whether you'd just like to provide a bit more background information, that would be very interesting.
I mean, Susanna could provide the information, but Chiara would be delighted to. New Institute of Public Health is great for everyone, isn't it, to understand that asset and capability. So let's meet up. I'll invite Susanna to respond.
Yeah, similarly, I mean, Chiara, it'd be great to talk more about this and together with colleagues from the Bangladeshi community. But I have to say that the magic fairy dust was good old making friends. It was relationships. We literally just, you know, sat down, had a very honest conversation about what the issues were, and you know, my credit to Ed actually for enabling us to bend the rules at the right time in the right way and do the right thing, actually, and make sure that we really took seriously the issues and the barriers that were there and acted at speed to remove those. And I have to say that in doing that, we built a relationship which is now paying dividends, as I was trying to explain, into the future and other issues. So mental health, and there's so much more we can do together. We learnt, we made friends, and I think that's a very different way for health and care to work with community groups. They're friends now, it's relationships, and it's a real partnership.
Many thanks, Susanna, for that. And if I could just ask a rather bespoke question myself, it relates to air quality. Now, I always used to think that I suffered from the ravages of poor air quality when I travelled down from Suffolk to Westminster and London. That was where I would be having the challenges. But actually, research shows that there is a serious air quality issue in some of our more urban areas, and in particular in Lowestoft, where we have got, in particular in the Kirkley area, the research shows that the air quality is of a very poor, and of course it's hitting hard in a deprived community. Now, I'm quite sure that's not just in Lowestoft; it will be in our other urban centres. So I just wonder, I just welcome any feedback from our panelists as to, and it may be something for the LGA as well, just to make, are we aware of the problem and what measures are being put in place to actually address it?
If I could start, so the most recent Health and Wellbeing Board of Suffolk has agreed to launch some concerted action around air pollution. Is that air pollution's, I've never realised this, but it's the fourth biggest killer, but behind cancer and cardiovascular disease and another. It's a real issue, and as you say, it often impacts the most deprived communities. So the district and borough councils obviously have specific roles and remit here, but from a health service perspective, we would like to move to a green fleet, for example, an electrified fleet for the ambulance service. There's all sorts of things that we could do to make a difference and make a contribution. So I think it's an important one to highlight, Peter, and I'm sure all health and wellbeing boards and integrated care partnerships will be discussing this and wanting to take action.
Yeah, if I may, Peter.
Yeah.
I think this identifies why it's so important that the integrated care partnerships are involved, because this is a responsibility that the district councils monitor, but it's not mapped by health, and therefore by bringing the districts and all parties into the ICS, then you can start to look at actually how, where are the issues and how are we as a system going to respond to them. And this feeds into the work that I'm asking public health to do, to really look at the population and at a very local place-based level to see what are the issues in the various areas. So as a system, we can see where the areas that need the most help are, and also the most specific responses. So air quality is really important, and I'm hoping that what we're proposing here is a system that will be able to leverage the work of all the different partners to deal with things that previously hadn't been considered as part of the health agenda.
Many thanks for that observation, Bill. That's really appreciated there. Now, any further questions from anyone to our panelists, or observations and thoughts as we move forward? I'm just quickly looking across the top of the screen.
Can't say any more, Peter.
Right. Well, I will just make a few concluding remarks. Many thanks to our panelists and to everyone who has contributed to what I think has been a very informative session. And I think the points I would make, and of course it came out right at the start of the white paper, at the start of this whole process, is that a place-based approach is absolutely fundamental to identifying the challenges. And moving on from that, it's the importance of it's again the whole team getting stuck into this. It's not just the NHS and the and locally and nationally. It's also, as we said, the social care, the councils. We've heard the role of the district councils from Bill there, and of course the voluntary sectors have a vital role to play, as indeed to the business community, and we've had very helpful contributions from the academic community, from the universities in the chat room today. So it's that team approach which is going to take us forward. We have various specific challenges in our own area in the east of England. We've heard that we do have some significant pockets of deprivation, particularly in coastal communities, which need to be addressed. We've got the worrying trend that for the first time since Victorian era, the life expectancy is going down. And of course, across the region, we are an elderly population. A lot of people move to the east of England. It's a great place to live, but that's in turn puts pressure on our health and care services. So those are the particular challenges that we've got to address. I think we often, when we in these meetings, we look for a particular issue to highlight to governments, reporting back of what we've done and what we need from them. And I think the one thing I picked up is, and it was what Bill highlighted, was that we must have a solution to the funding challenges that social care faces. And perhaps I don't think there isn't a nirvana of, hey presto, you join the NHS and social care together, 2 and 2 miraculously makes 5. I sense that is not necessarily going to happen. It will lead to better outcomes, more efficient working, but there is an urgent need for more funding for social care. Put that on a sustainable footing. That is I think probably a battle we will move forward over the coming months, rather than, I would suggest, specifically highlighting at this stage, but it will be one that will be very much at the centre of our minds going forward. I think that the 6 ICSs across our region, they will be working very collegiately with their other organisations in their areas. But of course, there is a need for coordination and collaboration across those areas, and there will be good examples of best practice which will evolve in a specific ICS, which other ICSs can pick up. So it may be that collaboration is something that the East of England Local Government Association with the NHS can look into, actually seeing what role can be played to deliver that whole region approach. I would just like to conclude by thanking all our speakers, to Alistair for very much setting the scene, and then to Ed, to Susanna and Bill for putting the devil in the detail. I would also like to give special thanks to Beverly Wilkinson at the Centre for Public and Policy Engagement, who prepared what was a very informative and detailed background briefing that all of us were able to read before the session. That was very, very helpful, and special thanks to Beverly for that. In conclusion, I'll just say that our next meeting is on Wednesday, the 25th of May. It's going to be a hybrid meeting, and I'll bring in Steve to say a few words about that. It's going to be the International Gateway, the East of England's key role in global Britain, and we're hoping that Grant Shapps, the Secretary of State of Transport, who has highlighted that he is an MP in the East of England, we hope that he will be able to join us for that meeting. But I'll just ask Steve now to say a few more words or concluding words about that meeting. Steve.
Just very briefly, thanks, Peter. Just very briefly, just to say that we're going to try the hybrid approach. We've got a room in the Commons, just off Westminster Hall, which will allow that facility. I'm going to try and learn how to do it, but it will be a first in-person meeting since the reception in October. Inevitably in Parliament, rooms are quite limited, and certainly limited in size. So I will probably invite people when we circulate an invitation to that meeting to register either as in person or online, and we'll try and make sure that works. But yeah, that should be an important meeting, and it will be exciting for those who can get there to actually have a meeting in person again. So look forward to that. That's Wednesday, the 25th of May, just after PMQs rather than before it. We're going to go for sort of quarter to 1 till 2 o'clock. And as you say, hopefully Grant Shapps will join us.
Many, many thanks for that. And on that note, I would like to bring what's been a very informative meeting to a conclusion. Thank our panelists for their contributions. Thank all of you for attending and for your proactive feedback. And many thanks to Steve Barwick who provides the group secretariat for help putting the whole show on the road. So many thanks to everyone. Have a great day, have a great Easter, and see you all hopefully on the 25th of May. All the best. Cheers. Bye.